Start.
Good evening, respected judges and my fellow batchmates. This is Satyasai Teja with Vishwasai Kumar Manadi, and today we are going to present a case of obsessive compulsive disorder. And a patient named Mr. X, 21 years old, 10th class by education. He is a salesman by occupation, Hindu religion, Telugu speaking, from rural background, with a family income of 12,000 per month, resident of Rajamandri. Came to a psychiatry OPD. The source of information of this case is from his father and from previous case he got files. The patient is presenting with repetitive thoughts of someone might hurt him, repetitive sexual images, sleep disturbances since 1 month. According to the patient attender, walking during sleep with seizure-like activity since 1 month, spending excessive time in washroom since 15 days. History of presenting illness. Patient was apparently normal 1 month back with good biosociooccupational functioning, going to work at garment shop in Bangalore from 9 am to 5 pm, staying at a PG hostel nearby with 4 other roommates. Since 1 month, patient reports of having thoughts that someone might hurt him, feeling fearful with ruminations of interpersonal relationship issues with previous co-worker, which is a minor conflict which happened 2 years back, reminiscing the confrontation between them due to recent brief online interaction with them on Instagram platform, where he was added in a group by past co-worker of food delivery job, but exited the group with the intentions of not wanting to maintain relationships with them. Patient started having repetitive thoughts that they might harm him, knowing that they won't hurt him, doesn't have an idea about what, which means they might harm him or they might get from hurting him, which are being excessive, unreasonable, associated with increased heart rate, feeling restlessness, feeling fearful, unable to stay at place, only finding some relief by sighing out loud multiple times during the day and hitting the wall. These are the repetitive thoughts are constant throughout the day, were unable to control the extent of disrupting his biosociooccupational functioning. With him avoiding interactions with the flatmates and current co-workers, he gradually stopped going to work with the fear that he may be confronted with the previous co-workers at his workplace or on his way to work. Patient complains of having repetitive sexual images throughout the day. Whenever he sees a female, sometimes a male too, which makes him feel guilt that he was having bad thoughts which might bother his family members for bringing the disgrace and that they might get harmed, causing him distress due to his inability to control and tries to hit the wall to curb these images and engage in masturbation practices in the private. He reports of having ruminations of these sexual images which he have gotten throughout the day before sleep, causing disturbance in his sleep also. Patient reports of doing repetitive acts like folding garments, washing hands multiple times. When he have done act 3 or 7 times, considering them as unlucky numbers, something bad might happen to him if he doesn't repeat the task. Reports of repeating the same word multiple times in his head, unable to control with the feeling that something bad might happen to him if he stops after reading the word once. Repeating reports that something bad might happen if clock strikes 3 o'clock or 7 o'clock, for which he is avoiding to going into rooms which have clocks when he notices the time clearly, approximately to those respective hours, that is 3 o'clock and 7 o'clock. Reports of feeling that something bad might happen to others if someone touches something he have touched before. So he avoids touching things like chair, table, household items, rather asking family members to arrange them. If he feels the need to move or keep them in a certain way, repeatedly asking questions others. 15 days back, he returned home and was taken to multiple temples as he was informed by the family members because of his fearfulness and feeling tense. He reports of getting abusive words in his mind towards the God, that is blasphemy. And he worries that he might say it out loud and tries to stop those thoughts by praying instead. He complains of sleep disturbances since 1 month with the fear that someone might hurt him with the problems in the initiation of sleep, sleeping at about 11 pm, where he usually sleeps at 9 pm, feeling drowsy in the following day. Patient attender, that is his father, reports that the patient PG mates have informed the patient that he is walking in the room in his sleep for a few minutes and getting back to sleep when they guide him back. Following these episodes, they might have noticed the patient decreased interactions with them and was lost in his own world, unable to meet their eyes when they try to interact with them. Since his return home 15 days back, patient attender noticed seizure-like activity, as in patient was getting up from his bed around 11 pm with the tilted head, protruded tongue outside, staring blankly and walking ahead aimlessly with tonic movements of bilateral upper limb. Stopped when the episode was interrupted by the family members and guided him back to bed with no memory of the episode, asking others what happened. But there were no confusion or problem in recognizing the family members and surroundings after disruption of the episode. The patient attender also reports of the patient insisting them to arrange these things around house, refusing to do so, and household chores or following any simple commands for the household help, like switching on lights or getting something where he used to do before. When question says that if he does them, something bad might happen to him. Patient attender reports of patient staying in washroom for a long time, about 15 to 30 minutes. There is an increased frequency of patient going into the washroom. When confronted, he replies that like washing his hand again and again. If he washed for 3 or 7 times, something bad might happen to him. Patient also reports that patient have been continuously saying that he was fearful, but doesn't mention why. And there was a history of seizures since 2014. Was under medication but discontinued since 3 years. History of substance abuse was also present. There was no history of fever, head injury, suspiciousness, wandering, disorganized behavior, hearing voices, seeing images, and fixed beliefs. There was no history of any possessive mode or crime spells and all. There were no suicidal thoughts. History of past illness. There were no similar complaints in the past. Patient is a known case of seizure disorder. First episode of seizure-like activity was noted in 2014 with the tonic-clonic movements of bilateral upper limb and lower limbs. Uprolling of eyes, frothing from the mouth, associated with tongue bite, not associated with any involuntary micturition, defecation. Lasted for 2 minutes with no history, any post-ictal confusion or irritability. Neuroimaging was done, MRI and EEG were normal. Kept on tablet sodium valproate, that is, and valproic acid for 2 years. There was a breakthrough episode in 2016 with the similar semiology. Then changed it to tablet Levipil 500 mg daily. He was under continuous medication till 2022 and have stopped them on advice by the neurologist to discontinue medicines, and patients sustained similar seizure-like activity with the similar semiology every 2 months, with the last episode being 3 months back reportedly. Occurrence of seizure-like activity with the change in semiology since 1 month, getting up from his bed with a tilted head, protruded tongue outside, standing up blankly and walking ahead aimlessly with the tonic movements of bilateral upper limb with no memory of the episode and no post-ictal confusion. Gradually, there is an increase in frequency of such episodes even present during the daytime. Family history. There is a history of seizures in paternal grandfather and no psychiatric illness in the family. Personal history. A patient is a full-term LSCS delivery with immediate cry after birth, attained milestones on time according to the patient attender as per comparing with the patient's elder brother. Immunization was done up to date, average scholastic performance and failed 10 plus 3 times. He have been working in Bangalore since 3 years initially as a food delivery guy, and then due to interpersonal relationships he stopped working there, then changed to bike mechanic, stopped worked there for 4 to 6 months and stopped due to his inability to work there. Then he changed his occupation to a garment shop worker. Now he's working, now till date he's working as a garment shop worker. And history of substance abuse was present. There was history of alcohol consumption since 3 years in a social pattern, that is 180 ml spirits, and history of smoking, that is 1 cigarette per day, but abstinence since 6 months. Sexual history reported having sexual knowledge, no previous relationships and no pornographic history. Pre-morbid personality. Social relations, maintains cordial relations with family, friends and co-workers and have limited long-term relations. Leisure activities, he listens to music, predominant mood, cheerful, relaxed, optimistic and stable character. Attitude towards the self and others. Patients are respectful and cordial towards others, unable to plan ahead and need to be guided, but independent at his work, takes decisions on his own based on his knowledge about his own strengths and interest in learning new things. Attitude towards work and responsibility. Patient is responsible and flexible, religious, energetic and takes initiative. General physical examination. There were no significant findings in the general physical examination. And mental status examination. General appearance, behavior. Patient is thin built, kempt and tidy dressing, hair, anxious facial expressions with constant sign throughout the interview. Eye to eye contact is maintained. No inappropriate looks or gestures. No catatonic signs. Rapport was established with difficulty. Attitude towards the examiner. Initially guarded and evasive, later cooperative. Posture is tense and changing. Psychomotor activity, increased movements, restlessness. And there were no extrapyramidal symptoms noted. Speech, it was normal with increased reaction time. Relevant with the prosody. Stream of thought was normal. Formal progression, no formal thought disorder. Kind of thought, obsessions, thoughts. Fear that someone might hurt him, something bad might happen to him or his family members. Blasphemy and sexual images. Where his thoughts are his own ego dystonic, intrusive, irrational and senseless, occurring against his will and tries to resist but fails, attains a temporary relief by yielding to some compulsions like sighing, bagging head over the wall and praying, associated with dysfunction. Magical thinking. Magical thinking is also present. Ruminations inferred as ideas of guilt. Mood and effect. Lost internal peace because of these thoughts. Affect anxious, congruent with mood. Thought appropriate to situation. Range restricted towards the anxious side. Reactive to the external stimuli. No active perceptual abnormalities. Sensorium and cognitive function. Patient is oriented to time, place, person and surroundings. Attention and concentration were intact. Memory is also intact. There is no appropriate general information and knowledge. That is not appropriate to patient's age. And judgment is intact. Inside grade was 4/6. Case formulation. A 21-year-old male, unmarried Hindu, secondary education, garment shop worker from middle socio-economic status. A known case of seizure disorder, currently not on medication since 3 years, with significant family history suggesting of seizure disorder in paternal grandfather and a significant personal history of alcohol use and smoking, accompanied by father history of being reliable but inadequate, presented with repetitive thoughts that someone might hurt him, repetitive sexual images associated with compulsive acts and magical thinking. Sleep disturbances is with seizure-like activity during sleep since 1 month, associated with biosociooccupational dysfunction with normal findings in physical and systemic examination and MSc revealing anxious facial expressions, restlessness, tense posture with increased psychomotor activity and increased reaction time with the ideas of guilt. In content of thoughts and obsessions, in possessions of thoughts and magical thinking, impaired social judgment and G4 insight. The differential diagnosis of our case was primary obsessive compulsive disorder, sleep-related hypermotor epilepsy, non-rapid eye movement parasomnia, temporal lobe epilepsy with psychiatric manifestations, delusion disorder, schizophrenia, and major depressive disorder. The final diagnosis was obsessive compulsive disorder with predominant obsessions and compulsions with mild intellectual disability disorder with a complex focal seizures. Management. As IP care is advised because of his restlessness and investigations were done. In the investigations, we can see serum prolactin is elevated, that is 70 mg. Normally it should be like around 20 mg. And biochemistry reports, we can see LFT. And EEG was done. EEG, we can see spike and wave activity, which indicates the presence of seizures. And NCC and MRI were normal. Ybox score chart was done for evaluation of OCD. Score was 31, which indicates severe sustained interference in the daily life. FLEP score, frontal lobe epilepsy and parasomnia score, which was +2. That indicates that favors frontal lobe epilepsy. Management. Patient was added on tablet fluoxetine 40 mg titrated to 60 mg. Tablet oxcarbazepine 150 mg titrated to 300 mg as advised by the neurologist. Other behavioral modifications for OCD, cognitive behavioral therapy and exposure response prevention. On follow-up, there is noted decrease in seizure activity and obsessive compulsive symptoms, and patient is currently maintaining well on medications. These are the journals which we took reference from. And he is our patient. A small video clip of him. So you can see he is walking in sleep with some seizure-like activity noted. And thank you. And today it's World Brain Day. Theme of the World's Brain Day was Brain Health Access for All. Thank you.